Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is brought to you by High Tech Answers and Healthcare Now Radio, part of the Answers Media Network, and is sponsored by the law offices of Myrick O'Connell. Now here is your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Tom Bizzaro, Vice President, Health Policy and Industry Relations at FDB First Databank. Welcome, Tom.
Thanks, Matt. Glad to be here.
Yeah, I'm very happy to have you on. And before we get into our main discussion around pharmacy, which is going to be a nice change of pace for the show, would you be able to let everyone know who you are and what you do with a little bit more detail?
Sure. I'm a pharmacist by training. I've actually been a pharmacist for over 40 years. So I've been in a position to see the changes in the profession over those years, as well as the change in the use of technology in pharmacy. I started out in retail pharmacy for a number of years. I moved into managed care for a few years, where I got a good sense of managed care pharmacy and also on the payer side. And then for the last 20 years, I've been at FDB. I started out as the manager of the group that acquired the data and did the data maintenance. I was in product management and then VP of sales and marketing. And then for the last, about 10 years, I've had this position as VP of health policy and industry relations. And of course, in this type of where we are with all the things that have been happening in healthcare, with the changes in technology and the government influence in technology, it's been a fascinating time to be doing health policy for FDB.
So I think you were just saying that for the first 10 years of your career, you were, let's call it a practicing pharmacist, if that's the right terminology. What made you decide to go from that side of the healthcare industry to where you are now?
Boy, is that a good question. I know that coming out of pharmacy school, I never could have pictured myself doing some of the things that I've done. In fact, some of those positions certainly wouldn't even have existed. But I was always enamored with pharmacy's ability to take advantage of technology in the workplace, both from a clinical perspective as well as the improvements it made financially. For example, electronic billing of pharmacy claims. Took a paper system and modernized it using standards to allow for almost real-time adjudication of claims and eligibility for patients. So as I saw the way that pharmacy changed to accept that type of technology as an advantage for both the business and for the patient, my interest changed somewhat into looking at how I could be involved from that side of the business.
So kind of saying, as you saw the willingness to adopt and utilize technology, kind of that description sounds like some of the changes that are the healthcare industry as a whole is kind of grappling with now. So do you think that, I guess, the pharmacy side was an early adopter in that type of technology?
Absolutely. I mean, the first pharmacy management system, the first medical record, or the use of the computer to help us do clinical decision support happened almost 35 years ago. And so pharmacy was way ahead of the game in healthcare for the use of that technology. And I think it happened for two reasons. One, there became more of a clinical demand on the pharmacist as the number of drugs and the complexity of the information that a pharmacist needed to have at his fingertips changed, as well as there was a very much of a financial incentive for pharmacy to computerize as it pertained to eligibility for third-party claims processing and then the actual claims processing. So pharmacy started, I think, very early on with the financial reasons for using technology. And that's changed over the years. The financial part of the business is still very important, but we had a clinical exposure also. In healthcare outside of pharmacy, in physician's office and hospitals, I think there hasn't been this combination of incentives until the last 5 to 10 years that would drive it forward. And of course, the federal government has very much provided incentives for physicians and hospitals to adopt technology.
Yeah, and kind of your reference there to the incentives for physicians and hospitals to be adopting, that's created a lot of reports about the headaches of the systems not doing what they're supposed to do. So since pharmacy made the switch without all of that federal incentive money, did it experience the same type of difficulties that the rest of the healthcare industry is facing now?
It certainly did. So when I started using a computer in the pharmacy, I like to describe it this way. I think in the beginning, those systems were developed by pharmacists who had an interest in technology or computer science, or maybe they had someone else in the family, and I mean this literally, that had an interest in computers, and so they tried to adapt what a pharmacist was doing in the retail setting to what you would need to support that using a computer. So those systems were designed, and they were poorly designed, honestly. Secondly, we had a computer science industry looked at pharmacy as a potential market for their products, and I think those first systems that came out that were more technology focused instead of pharmacy focused also were not, in general, were not real usable. And what changed, of course, over time was the collaboration between the technologists and the pharmacy clinicians to develop the systems that we have now that in pharmacy are fantastic. They're efficient. They improve the care to the patient. I've mentioned how they've improved the financial well-being of a independent or chain pharmacy. And so that evolved over those 30 years or so. And so, yes, pharmacy suffered through it, but we've had a lot of time to refine those systems. And the core developers, those systems that did not meet the needs of the pharmacist, those have gone by the wayside. And I think we're seeing the same thing in other areas of healthcare, where the systems are evolving and becoming better and better. And I should also mention, in all fairness, is the complexity of the healthcare systems that we're talking about in a physician's office or in a hospital especially are much more complex than they were in pharmacy, as pharmacy was drug-centric. Now that's changing also, but I think pharmacy was able to focus in one area and then expand the usability of the computer system in a way that I am very hopeful that physician system vendors and hospital system vendors are going to be able to continue to improve their programs and systems.
Yeah, and it feels like with kind of that long iterative development process that you were just describing, because I want to say because it feels like it was like a self-driven and self-adopted process. It sounds like there was a bit more freedom and flexibility in terms of being able to take that time to really get to a system that works and does what you really want it to do. Whereas that might be a key difference from what hospitals and physicians are experiencing now, where we're saying first they were driven to adopt these systems by all this federal money, and now everyone's looking at it like, well, what did we spend all this money on if the systems aren't doing what we thought they were going to do?
Yeah, that's certainly true. The development of the requirements for the federal government allowing you to partake in the incentives, I think, was a little bit misguided. The meaningful use requirements were prescriptive about what you had to do to become eligible as a meaningful user, either as a physician or as a hospital system, to receive those funds. And I think what's changed now, and we're seeing this now in what ONC is doing, the Office of the National Coordinator, and HHS is asking, is we see more and more of a movement away from these detailed requirements as to what you have to do in a system to one that says, I want you to improve the outcomes for a patient. So I'm not going to tell you exactly how to do that, but I want you at some point in time to be able to prove to me that what you're doing is improving those outcomes for the patient. And by the way, also doing it at a price point, a cost that is less than was acceptable in the past. So there's no question that some of those incentive requirements were very much, I think, I don't want to use the term arbitrary because I actually think the HITECH Act did, a great service to getting folks in healthcare outside of pharmacy involved in accepting and developing the use of electronic systems. But I think they were very much too proscriptive, and that the pattern I'm seeing now about letting the physicians, the hospital providers develop their systems that will provide better outcomes, and then measuring those outcomes makes a lot more sense. But it's iterative. It certainly is, and it needs to continue to develop and change, and hopefully we'll continue to see these improvements, and that physicians will be spending less time in front of the computer screen and having systems that are making their job more efficient as well as improving outcomes.
Yeah, no, and I think you've definitely raised a number of very good points there, which is some spur needed to be done to get the adoption, just to get all to get the digital tools into place. You certainly can argue whether or not the measures that were then used to determine if something was good or not, were successful. But I think you're also very right in saying that now physicians and hospitals are at that point where they're figuring out, okay, how do we make it actually fit what we need? How do we use it to help drive better, higher quality, less costly care? So as we're moving into that phase, what lessons could that segment in the healthcare industry learn from pharmacy, which, as we were saying, already went through that entire, iterative process of first rolling out something that seemed like a good idea, didn't necessarily work the way it was intended, and have now been working on it to the point where, as you said, it does fit in and really enhance the delivery of pharmacy care.
I think one thing that we need to focus on is the workflow in the physician's office or in the hospital, and make sure that the systems that we develop are not interfering with that workflow. Now, that doesn't mean that a physician will not have to change the processes he uses for treating and seeing a patient. And it does not mean that a developer should demand that a physician do something this way because that's the best way that computers work, right? So there has to be this collaboration and acceptance on both sides. There has to be some change that will allow the development of these efficient systems. So in pharmacy, I know that I had friends and colleagues years ago who left the pharmacy business when it became evident that you had to have a computer in the store to remain viable both clinically and financially. And some of those gentlemen and ladies decided to retire, and we're hearing that now with some physicians too. And it's a bit sad, but it's the way the world has changed. We do have to be adaptable in our professions to take advantage of the new technology. Saying that, I also am very much asking that those developers of systems take into account the patient and what a physician needs to do to give the patient the best care possible. So it's a collaboration, and I think it's also a willingness in some cases to compromise. Now, physicians that talk about, I'm not going to spend all the time in front of a computer, well, hopefully at some point in time, although you'd be spending a little bit of time in front of a computer, not spending hours writing up their notes for after office hours for the medical record that was on paper. So it's a collaboration in the company.
Yes, definitely. And for those of you just joining, I'm talking with Tom Bizzaro from FDB, First Databank, and kind of taking off that point that you were just talking about the collaboration and thinking about care. I'm going to use that to shift gears a little bit and dive a little bit more into what pharmacy and the pharmacist role actually is within healthcare, because I get a sense that all of us walk into a pharmacy on a fairly frequent basis, but I think where the role of the pharmacist fits within the larger healthcare scheme maybe is overlooked or not fully understood. And to me, it seems like it's also in a state of flux, just like the rest of healthcare. So if you wouldn't mind, would you just be able to kind of, as I said, help give a little bit of a framework for what the role of the pharmacist has been and how that's changing as we get into more of a quality-focused world for healthcare?
Yeah, I think it's changing drastically. And I think that pharmacy education has changed drastically also to have a much stronger focus on the clinical skills of the pharmacist now. And of course, when I came out of pharmacy school, it was a bachelor's degree, a 5-year program. Now, pharmacy degrees are doctors of pharmacy, and they're 6 or 7 year degrees. And so that has changed with much of a focus on the clinical side of pharmacy. So I think that, people look at pharmacists as a dispenser of drugs. So he's the guy behind the counter that is counting and pouring and comes out to say hello or to ask you a question about your care occasionally. I'm talking about now in the past when I came out of pharmacy school. And when I came out of pharmacy school, it was still oftentimes in some states, you were not allowed to put the name of the drug on the prescription label. So can you imagine that, where we had a time where you would dispense a prescription to a patient and the actual name of the product in the bottle might not be on that prescription label. So we've gone way past that now. We're more capable of getting online and finding out about their drug products, finding out what's available to them. So they're much more knowledgeable. So pharmacists are changing drastically from someone who provided you a tablet in a bottle or a liquid in a bottle to someone who should be providing you the information that you need so that you as a patient understand why you're taking the drug, what the risks are in taking that drug, and what you need to do to be a caretaker for your own care. So pharmacists are going, I think that within just a few years, with the way that we have changes in automation, the use of pharmacy technicians, I don't think a pharmacist should ever be counting or pouring in the future. I think that should all be done by a third party, and that the pharmacist's clinical skills are used exclusively to help that patient understand the needs, the advantages, the risks of taking that drug. And we're starting to see that. We're starting to see pharmacists becoming more involved in the actual care of a patient. We're seeing pharmacists becoming less of a dispenser of drugs and more of a provider of primary care. And I think it really started when pharmacists got the capabilities and permissions in state by state to do immunizations. And so we now look at a pharmacist as someone who is providing care that had very little to do with the provision of the drug. It's more now of the administration of a drug and becoming a source of care to a patient that would not traditionally be related to the pharmacy profession. So we started with immunizations. Now we have pharmacists in some states who can actually dispense certain types of drugs. We have pharmacists who can order labs. We have pharmacists that have collaborative practice agreements with physicians so they can do more and more as a member of a healthcare team with the goal of doing two things. First, to improve the outcomes in care for the patient, and second, to do that at a cost that is less than we're doing or seeing now.
So with that kind of, as you said, more clinical role, I'm just going to apply probably what's a fairly limited personal experience to it, because usually I'm going into, and I won't use names, but one of the large pharmacy chains, and it just feels like you go up to the counter, you say here, my prescription was called in, or here it is, you wait, and it's handed to you, and there's not, or maybe at least in my area, where in the Northeast, it doesn't feel like there's that type of interaction that you're describing. Although at the same time, there was one time, I was still within Massachusetts where I live on vacation, and I went to a more, community-based, locally owned pharmacy, and had a very nice dialogue with the pharmacist because, one, he was the owner of the place, but two, he wanted to make sure I knew what was going on. And, it was definitely more along the lines of the interaction that you were describing. So in terms of that expanding clinical role, is it happening everywhere, or is it kind of in pockets right now? And how does that play into that difference between, the more local community type pharmacy and the larger chains, which I think are more ubiquitous and the ones that people more frequently probably interact with?
Yeah, Matt, you've really described the issue that we have to get to see how we continue to expand the pharmacist role in more of a primary care provider. And depending on the store you go into and the chain or the independent pharmacy, you're going to have this huge spread in the type of care that you receive, no question about it. Independent pharmacists are so busy in running the business in the pharmacy of the store that some of them don't have the time to provide that type of care that I'm speaking about. In chain pharmacies, you hear that also, right? That the pharmacist is so busy in providing the service of dispensing a drug that he doesn't have time for that personal participation with a patient. And then let's go to where I want to see us go. We go to the independent pharmacy who has made a commitment to provide that type of individual care to a patient. So maybe he's got a little area in the store where you can go to for your consultation with a pharmacist that gives you more privacy. Or he's made a commitment to hire enough help so that he can spend the time with that patient and provide that type of care. In the same area in chain pharmacies, we're seeing some chains that are setting up consultation areas also in a manner that would allow for private consultation with a pharmacist. Some chains are providing, the pharmacist is now no longer behind the counter. The pharmacist in some stores is out in front of the counter, accessible to the patient, and has a very, very limited role in dispensing. It is mainly there to provide that type of personal care for the patient. But it's all over the board. I would say that your description of your first description of how you went in to get your drug, and it was handed to you, and someone said, "Do you want to speak to the pharmacist?" And that was the breadth of the consultation that you might have had, as to one where you get someone who comes out and says, "Here's why you're taking the drug. Make sure that you take it with food. Here's the risk that you might have to deal with to get the benefit of the drug." So it's all over the place. But I think pharmacy has to continue to change in that the owner of the pharmacy, whether it's a corporation or an independent businessman, has to make that commitment that they want to see that role continue to expand for the pharmacist and take advantage of what I see as financial incentives as part of a care team, instead of being paid for the actual drug product in the dispensing kit.
Yeah, no, and picking up on what you just said about, becoming part of the care team, and I think also kind of circling back to how, at the beginning we've been talking about, a focus on quality. How do you see pharmacy becoming more integrated in terms of, creating more coordination across the spectrum of care, which really, so breaking down those silos between each area of healthcare?
Yeah, first, if you look at the pharmacists and their accessibility, so there's pharmacies, in some cities it seems like there's 2 pharmacies on every corner. Even in most rural areas, there's a pharmacist within 5 or 10 miles of most citizens. And so pharmacists, because of their accessibility, and oftentimes because they have a personal connection with a patient who is in a store more than once every quarter or more than once every year for their checkup, like you would see in a physician's office, has that ability to get a personal relationship with a patient because of their accessibility and the frequency of access to the patient, and for the patient to the pharmacist. So I think that the pharmacists are being viewed by a healthcare system now that sees that accessibility as a huge advantage. So we know that there can be a huge improvement in care if we could just get people to, first of all, pick up their prescriptions the first time, and then take those prescriptions the way they are prescribed over the course of time, that we can have a huge impact on the outcomes of the patient simply by making sure that a patient is taking their drugs. So who's better situated to do that than a pharmacist? And I'm not talking about a automated robocall to remind you to pick up your prescription. I'm talking about a pharmacist who's going to pick up the phone and call you and speak to you personally. Or for some of my younger colleagues, would much rather receive a personalized text from a pharmacist, not a robo-text, but a personalized text from a pharmacist, someone that's showing that there's an interest and a concern for their care. And so pharmacists are uniquely, I think, situated to be able to do that. And as we become a health system that stops paying for individual points of care, stops paying for a lab or a surgery or a drug being dispensed, it becomes more that has a responsibility for the total care of the patient, where all those things are combined, and the benefit is to the patient has an impact on the reimbursement to that entity. So that entity is no longer those individuals providing the care, but each one of those healthcare professionals, as part of that team, is reimbursed dependent on the outcome for that patient. And so, you can call it managed care, you can call it accountable care. I don't think there's any question that we've got to move away from fee for service for these individual actions of a healthcare professional to one that looks at a patient's overall well-being and care.
Yeah, no, and I think that is a very comprehensive and hopeful description. And unfortunately, believe it or not, but we're already out of time. So I'd like to thank my guest, Tom Bizzaro, for a great conversation today.
Thank you, Matt. It's been a pleasure.
Yeah, and thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.